This conference will now be recorded.
Hi, everyone. This is the AnCan High Risk Recurrent Advanced Prostate Cancer Support video chat. And I'm Len Sierra, and it's Tuesday, January 25th. And we're going to get started with a newcomer, Tom Madison. Now, Tom, I'm going to ask you a few questions. And just to keep things in chronological order, it helps us to structure the questions for you. So, Tom, how old are you?
76.
Okay. And where do you live, Tom?
I divide my time between Stockholm, Sweden, and Madison, Wisconsin, hence the last name. I'm in Madison right now.
Wow. Okay. How much time in Stockholm?
Well, until the COVID hit, it was about 6 or 7 months a year. But we bailed out after 6 months of the Swedes dealing with COVID and came back to America.
Right. Okay. So, how did you hear about us, Tom?
Through my cousin, who had been dealing with his prostate for about 15 years.
Is he a member of our group?
I believe he has participated in a number of your groups. That's why he recommended it. And I went to a group last Wednesday night just to practice. I think Nick was there and invited me back to this one. I'm not sure this is the right group for me, but
Well,
I thought I'd start here.
okay. We'll find out soon enough. So when were you diagnosed, Tom?
I got diagnosis. I had an MRI on the 30th of November, got the results December 1st.
Okay. And what was your Gleason score?
Well, this was from an MRI, so I don't have a Gleason score, but I do have it from I had a biopsy a couple of weeks ago.
Okay. And so what was the biopsy Gleason?
Well, they did 7 biopsies, and it was 9/10 on all of them except one was a 10+10 or a 5+5.
Right.
Okay.
Okay.
Did I hear a whistle?
Yeah, that was a whistle like wow.
Yeah.
But
I'm a
similar stage.
I'm a professor, and people have looked at this, complained that I'm always trying to do better than everyone else. So,
Yeah. Yeah, you went right to the top there, Tom.
right.
Okay, so what was your PSA?
13.7.
All right, and that was either late November or early December.
Yeah, it's December 1st.
Okay. Where are you being treated?
UW Health in Madison.
Okay, is that where Dennis McGuire is being treated, Rick? Do you know? Is that the Carbone Center?
Yes, that's the center.
Okay, yeah, we've got someone who's being treated there also.
Great.
It's a good place to be. And which doctor? I assume you've only seen a urologist so far, or have you seen a medical oncologist?
I've seen you don't get to see these people very much. This is not a good time to get sick because hospitals are a little pressed.
Yeah.
David Jard is the surgeon who did the biopsy, and given the results, he's shipping me off to a guy by the name of John Floberg, Floberg, a radiologist. I'm sorry.
Oh, okay. So they're recommending radiation therapy for you first.
Yeah, there's a lesion on my prostate that had broken out through the case, and a fairly large lesion, which did show up as all of my 7 biopsies did, to have significant amounts of cancer. And Gerard says, and at least it confirms with what I've been reading, but I'm willing to have my mind changed. That's why I'm interested in what you guys think. But it's partly because of my age and the fact that it's probably spread to other parts of my body. So that's where he wants to start. And I'm getting a PET scan, and I'm not quite sure which kind of a PET scan later next week before I meet with Floberg.
Okay. Have they put you on any kind of hormone therapy yet?
No,
Kind of surprising, but okay. Did they say they will start it before the radiation?
I think Gerard just sort of rules out surgery. He's a very good surgeon. He's operated on a lot of people I've met over the web as well. So I think when it comes to other things, he doesn't meddle. He just pushes me on. But I'm
Yeah,
not sure.
yeah, surgery would not be appropriate for you.
Right. But no, they have not. Nobody has talked to me about hormone therapy, but people have not talked to me very much. So that's one of the reasons I'm here.
Yeah, that's a little bit troubling considering you are very high risk. They should have a sense of urgency. In our opinion, I'm sure I'm not the only one thinking that right now.
Well, that's certainly what I'm thinking. I have arranged for a second opinion. It'll be the week after next down at the University of Chicago. It looked, as I was reading about prostate cancer over the holidays, Merry Christmas, it looked like this was sufficiently complex that it was good to get second opinions if you could. So I've made an appointment in Chicago, which is not easy to get to from my point of view. I'm not much of a driver and I don't have much of a car. So anyway, I'm surprised that the people in Chicago have not seen either my biopsy or my MRI yet.
Okay, I don't suppose they've done any genetic testing yet on your biopsy specimen?
Nope.
Or a blood test for inherited mutations?
Nope.
Okay. And you haven't seen a medical oncologist yet, a GU medical oncologist?
That's right. I have not.
Okay, maybe some of our guys, Rick, may have some suggestions for you.
That would be great.
Yeah. And so far, the only scan you've had is the MRI, but you have a PET scan plan, but you're not sure the name of the PET scan.
Yeah, I asked Gerard about it, and I said, will this show up stuff on the bones? And or also there's an Oxymin scan that I've heard was important to get, but he said this PET scan will show something about my bones. The MRI I had showed lesions on the bones. Multiple enhancing lesions on the bony pelvis are suspicious for metastasis. And additional enhancing the lesion of the proximal left femur is also suspicious for metastasis. And also they looked at the lymph nodes and suggested that they were suspicious for metastasis.
All right.
So Tom,
How do you
I guess
feel
I'll
about chemotherapy, Tom?
Pardon me?
How do you feel about chemotherapy? That might be the most appropriate choice for you, judging by recent clinical trials that have been run.
Well, I'm not excited about it, but it seems like it's one of the obvious things that we should be doing.
Yeah.
Well,
Did you have any symptoms? Hold on,
No,
Herbert.
my symptoms have just, when I went in, they scheduled me with a doctor after I had or before I had my MRI, a guy who does what, BPH, benign prostate, whatever the last word is.
Right.
So they didn't have any inclination that I had this level of cancer in my prostate. And so when they got the results, they called me up, and some poor nurse had to give me the bad news over the phone. I think she did a pretty good job. But then they said, well, you don't want to see this doctor. He specializes in BPH, and you need to see someone who specializes in uh, cancer,
Yeah.
prostate cancer. And then we wanted to get a MRI or a biopsy as soon as possible, but the Christmas holidays were coming up, and we had plans to go to California to see our family. And both couple of doctors said it would be okay to put off the biopsy till the first week of January, and then turns out whoever does your biopsy sort of heads your case. And Gerard has such good reputation in the field. I waited another week so I could have him do my biopsy.
Oh, wait, I thought Gerard was the radiation oncologist.
No. Floberg is the radiation guy. Len.
Oh,
Gerard is the urologist.
Right.
okay.
Thanks, Nick.
So, Tom, is there a history of cancer in your family?
Not particularly, no.
Okay. Well, okay, I'm gonna open it up to you guys. See, do you have any specific questions for us before I?
Well, you're sort of answering them in kind of a backhanded way. I'm wondering how serious this is, and what would you guys do if you were in my shoes with these two
well,
data points?
well, Tom, I was a Gleason 10 with many lesions and bone-specific disease, and I would do a lot if I were you, and I did a lot.
Okay.
Okay.
Who am I talking to here?
This is Herb Geller.
Okay, Herb. Thanks.
First of all, I'd really want to know where the disease is and how much of it you've got. Okay. And the way you do that, and again, is an appropriate scan. And yes, it's a PET scan, but the current type of PET scan that's going to be most useful is called a PSMA PET scan.
Yep.
PSMA is a tumor-produced antigen that is produced by prostate cancer cells, and by imaging it, it's a very sensitive method for determining where your cancer is. And determining that you have METs, or that it's outside the prostate, would argue that the appropriate person to treat you is a person who treats systemic disease, not a surgeon and not a and not a radiologist or a radiotherapist.
Radiation oncologist.
Right. You don't need a radiation oncologist yet. You really need to assess the level of your systemic disease. And the appropriate person to do that is a gastrourinary oncologist, GU oncologist.
Genitourinary.
Right. Sorry, Rick. I'm really addled tonight. Genitourinary oncologist. And then they need some more information. And as Lynn brought up, they will want to, if they're any good, they're going to want to know what the genetics of you and your tumor are, right? Because that points to therapeutic possibilities or needs.
So how do I
And
do this? Do I call up Jard, or do I call up Floberg and
well, I
say,
would, if
you're
you
not the
say
right
Gerard
guy?
is in, I'm really
No.
surprised that Gerard sent you to a radiation oncologist. If he
Really?
knew what you knew, you told us, he should
Yep.
have sent you to a GU oncologist, a medical oncologist immediately.
All right.
He shouldn't have let that slide, in my humble opinion.
Yeah, no,
And
Herb,
then
I don't think you're wrong, Herb. And there's a couple of things. You said you set up an appointment for a second opinion. What sort of doctor did you set that up with, Tom?
Guy by the name of Ashka Patniak, and he does quite a lot of work in immunotherapy. This is a sort of a, first screening at the University of Chicago.
Is he a urologist? Is he a urologist? Is he a radiation oncologist, or is he a medical oncologist?
Okay, here's what it is. He's a medical oncologist specializing in genitourinary cancers,
Genitourinary. Okay. So,
including prostate, bladder, kidney, testicular, etc.
right. You're with the right guy. You're with the right type of guy. That's not the doctor that we would choose there, because he's a more junior guy. The guy, if you could get in, maybe we can help you, I don't know, would be to see either Walter Stadler or help me, somebody. I've just lost his name.
Shmulewicz.
Shmulewicz, thank you. Yeah, Russell
But
Shmulewicz.
this is at Chicago, right?
Yes, this is at the
Uh,
University of Chicago in Hyde Park.
Yeah.
Okay.
There's also a couple of good ones at Northwestern, which is might be a little easier for you to get to.
Yeah. I mean, if you're looking for a second opinion, then you could also see what's his name, John
Vanderweel.
Vanderweel.
but wait a minute, Rick. What about a first opinion at Wisconsin?
Well, I'm coming to that.
Yeah, right, exactly. I really want to be treated at Wisconsin
Right.
because that's where I live.
Let me hold your horses. I'm coming to it.
Okay.
We would suggest one of two doctors, and I would insist that that's the next person you see. I'd cancel your appointment with Floberg and tell him you don't want to see Floberg. You either want to see one of these two doctors, either Glenn Liu, Liu, or Joshua Lang, Lang. Okay? Those are the two guys that we know that we've had guys see. Dennis McGuire isn't on the call today, but he's currently a patient of Lang's. He likes him a lot. Glenn Liu's been around a little longer. I think if you could get in to see Lang, that would be the best, and Lang should see you. And that's just, to me, I agree with Herb, with Len, that's your starting point.
Spell the words you were telling me about.
Lang, Lang.
No. I got the names, but it's the kind of person I am after.
Okay, it's in the chat window. If you open the chat window, someone's already put it in there for you. So you'll get it afterwards. It'll be there for you in that chat window by clicking on the little speech bubble.
What?
So basically, you need a medical oncologist, someone who is trained in internal medicine and then subspecialty of hem-onc, and then a fellowship in genitourinary medicine.
Actually, Herb, it's no longer a subspecialty.
Really?
It's it's oncology is now is a specialty. It has been for a while. It used to be years ago. You were right. You're right. It used to be a subspecialty of intern. But
No, but I mean, if you need a fellowship in GU.
right. But you need a genitourinary medical oncologist. Now, there's something else that you should know. Okay. Floberg is probably the right guy for your radiation. They're doing some interesting work at Carbone, where at some point in time, you may need, it's not sure because it depends on your treatment choices, but if they need to radiate your pelvic girdle, which could be, then they're actually doing some trials at Carbone using stereotactic body radiation therapy, SBRT, which is a very intense focus type of therapy. And it's usually used and directed at a small tumor or at a small area like the prostate. And it's not usually suitable to be delivered in fractions across a wider area. But they're actually doing some work in that space at Carbone. So that's something, if you decide that you're going to proceed with the radiation before you do anything else, is something I would investigate. But if it were me, the most important things I would do in the following order would be first to see a genitourinary medical oncologist, a GU medical oncologist, and secondly, to ask him and insist that you want a PSMA scan.
Right.
And that PSMA scan is likely to be either a gallium-68 based scan, or it may be an 18F based scan using Pylarify, Pylarify. I don't know if Madison is offering, if Carbone is offering, but if they're not offering, tell them that, let's find somebody local who is, because if they're not offering the Pylarify, they probably won't be offering the gallium scan either. But that's not for sure. You've got to ask for it. But that PSMA scan is hugely important because that's about the only type of scan that will really define where your lesions are. The Adjuvant scan may work, especially with what did you say your PSA was? 13, I think.
Yeah.
With a PSA of 13, the Adjuvant scan may work. So if that's what they offer you and you don't want to push the envelope, I take it. But if you can get a PSMA scan, you're better off.
Well, why didn't they offer that just to start?
There's a lot of reasons. I don't want to say it isn't standard of care because the NCCN is now recommending it, but it's too new. A lot of this stuff is very new, especially the Adjuvant scan. And they're not offering it frequently enough to men who are diagnosed with high-grade disease. And we've just encountered this. We just had a guy who went and got a scan yesterday in Seattle, had to go up there from Bend, Oregon to Seattle, and his insurance refused to pay for it. But this is a guy who really needs it in order to make a treatment decision. And essentially, we're ahead of where a lot of practitioners and a lot of insurance companies are. We're not ahead of Dr. Lang, and we're not ahead of Dr. Liu, and we're not ahead of Dr. Shmulewicz. They would all agree.
Who's the third doctor? And where? Shmulewicz?
Shmulewicz is one of the options in Chicago, Shmulewicz or Stadler. And somebody will put the Chicago names in there. But like you said, you want to get treated in Madison, and I would look to Lang as being the guy to start with.
So I call up which one? I call up my regular doctor, or I call Chicard and say, I want to shift doctors.
Right. I
Yeah,
would
you
call,
call Gerard.
if you're telling me that Gerard is he was the big shot there, he will
Yeah.
get you an appointment with a GU medical oncologist stat.
But why did he get me an appointment with a radiologist?
I don't know. You can ask him.
You should be asking him, Tom, not us.
Right.
But
Okay.
let me tell you something else you need to do as well. You mentioned your biopsy report. Have you read your biopsy report yourself?
Yeah.
Okay. Is there any mention in that biopsy report of cribriform disease or intraductal disease?
I don't think so.
You need to ask Gerard. When you call Gerard, the first thing I would ask him is, did the pathologists investigate these specimens for cribriform and intraductal disease? Because a lot of times they're not doing that, and you have to ask them specifically to do it, and it's not being done. So one of the things that we've learned over the last 9 months or so is that you need to specifically ask for whether the pathologist did that, and if they didn't, for them to relook at the slides for cribriform and or intraductal disease, because that can also make an impact. Even though you have such a lot of 9s and 10s, it can make it easier for you to get the insurance company to approve this PSMA scan. That's the first thing. You could also send your slides off for a second opinion, but you know, when you've got so much 4 and 5, I don't think it's going to make a huge difference other than to tell you whether the disease is cribriform or intraductal. And if you ask the Carbone pathologist to look specifically for it, if they haven't, I think you'll get a reasonable answer from them because they're good enough.
And what are those things again? I'm sorry, I get overwhelmed with information and jacking up the fear level.
Okay, so it's cribriform, 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 or intraductal. Now, Tom, you don't have to take these notes down because people are putting it in the chat window, and you can recover the chat window afterwards.
How do I do
the information is going to be there for you.
I can see it. How do I get the chat window after the session?
We'll tell you momentarily, but we promise you it's backed up. Okay. And Ben Nathanson will, if he hasn't already done it, he probably has, knowing Ben, he'll put in cribriform and intraductal.
Joe just did.
Those are the things that you really need to be asking Gerard. And then you say to Gerard, Dr. Gerard, I need a PSMA scan, because if I have metastasis, which is quite likely from the MRI, and if there's more than 5 spots, maybe I don't start with radiation oncology. And he's going to say, well, yeah, I suppose that's true. And then you're going to say to him, well, I'd like to see Dr. Lang, please, as soon as possible.
Okay. Can I call Lang myself, or can I have my regular doctor call Lang?
I would go through, since you've already opened the door at Madison, and you've got an appointment set up with Floberg, which I would not see Floberg until you've seen Lang. But I would go through the channels there. Do you know if maybe Chick knows, do you know if they have a nurse navigator in the prostate cancer group at Carbone?
I don't know.
I don't know.
Okay, because if they have a nurse navigator, and you get hold of the nurse navigator, they will make sure this happens, because that's what their job is. You see, unfortunately, a lot of times, not just with prostate cancer, but everywhere, doctors think in boxes.
Yep.
And so what we have to do is we have to get them to think
Outside the box.
more openly and more widely.
So Gerard
Gerard,
decided I needed radiation because I didn't need surgery.
well, but he wasn't thinking widely enough, because it didn't register with him that your disease could be even more advanced. But I think we're sort of we're flogging a dead horse at this point. I think you got the message.
Right. I think the message is a GU oncologist to guide your case. Number two, a scan so you know the extent of your disease. And then
And the scan that I'm getting is not sufficient. Is that correct?
we don't know what you're getting. You don't know what you're getting.
Okay, it just said a PET scan.
Well, PET is a method. There are different ways of PET imaging. We
And I
think
want the
PET,
PSMAI.
PSMA PET is the one that's the most likely to give you the most sensitive results.
Okay.
So once you get that scan and once you get the GU oncologist, things should fall into place. I also would tell the GU oncologist if there's any suspicion of metastatic disease, and this was brought up at the beginning by Len, you should probably start with androgen deprivation therapy soon.
Okay.
And I think taking that away is enough. It'll get you going, but you really want to get to that GU guy fast.
I have a couple of things to add.
Thanks.
I agree with Herb and Rick, but the PSMA has some limitations. About 20% of the people do not express PSMA, or they will have metastases that don't express PSMA. And so I would get both the Axeman and the PSMA, or the gallium or PYL, or PDY, I guess it is, PDY. The other thing I would strongly recommend is that you get the book by Mark Schulz, The Key to Prostate Cancer. It's an excellent book on prostate cancer.
I've been using this other one by the guy at Johns Hopkins. This one. I don't know if you can see it.
He's a surgeon.
Walsh, yes.
Yeah, I would strongly recommend the book by Mark Schulz, The Key to Prostate Cancer. He's a medical oncologist, and he's not as biased as Patrick Walsh would be.
Right.
Although he's very biased against surgery, but you're beyond surgery.
Right. So what's
That's
the
a good
guy's
book,
name again?
but it's about 20 years old, so better off with a more current book on prostate cancer.
Which is the
The
more,
book on Walsh is about 20 years old.
well, the Walsh this is the 4th edition. It just came out in 2019.
Oh,
I mean,
okay.
all textbooks are out of date, particularly in a field like this. But
Yeah.
what's the Key to Prostate Cancer, and the author is?
Mark Schulz.
SCHOLZ.
Okay, this is really, really helpful. I wish I'd had this talk 3 weeks ago, but it's good to have now.
Well, you can always come back next week, Tom, and let us know what kind of progress you made, or maybe you'll have new questions for us, okay?
Okay.
Come back next week. It's Monday next week.
No, Len, careful.
Oh, no?
No.
Okay.
We'll talk about next week before the end of the meeting, but it's not on Monday. We have a very good presentation on Monday, but it's not a prostate cancer group.
Right.
So let me just would somebody like to explain to Tom how he can recover? Are you using a PC or are you using a Mac,
A
Tom?
PC. A PC.
Okay. So, all right. So if you open the documents file, you'll find something that starts chat log. CHATLOG.
Where is the documents file?
Folder, a folder.
It's a folder.
Bring up Windows Explorer and you can click on that.
I got a lot of files called documents.
Or
Now, this is a folder, it's not a file.
Yes.
I'll let
okay.
somebody else do it. I don't want to confuse him. Go ahead.
you need to bring up Windows Explorer, not Internet Explorer.
Right.
You can hold down the flag key and hit E to bring it up quickly. And then documents is, you said documents, it's on the left.
You want me to do this now?
No,
No,
just make a note of it. It's in the documents folder. And you'll see something that says chat log, AnCan Barniscus room, and today's date.
And that's downloading onto my computer, this whole thing? Will be in
Yes.
my
yep, automatically.
the chat log or the whole video?
Just the chat log.
The chat log, just the chat
Okay.
log. Okay?
No.
And if you click on it, it'll open a Word document with all of the messages that are in the chat log.
Okay. What's the name again in documents?
Larry had suggested, and I think this is a great idea, we just mail it to Tom.
Yeah.
No, I don't want to create that sort of a precedent, Ben. We cannot do this.
Okay.
Okay? It would be very nice, but then we're going to have to do it for everybody, and we don't have the resources to do it. Men have to be able to be just to help themselves just a little bit. This is not that difficult.
Well,
So, you open the documents file, you'll see chat log, AnCan Barniscus, and the date. And you'll open that file. If you cannot find it, you can send an email to info@ancan.org and we'll help you. The other thing is,
Or if you sort
The
by
other
date,
thing
it'll be at the top.
Herb, hold on. The other thing is that these meetings are recorded and they're on YouTube and they're also on the, we post them to our blog. So sign up for our blog and we take the chat and we post the chat both on YouTube and on our blog, but that may not happen for a few days.
okay.
Okay.
Thank you.
Tom, do you know how to take a screenshot?
No. I take them and then I forget how I took them.
Okay, never mind. That's all right.
We don't have
No,
time for computer lessons right now, okay, guys? Let's
Right.
move on. It's 10
Yep.
minutes.
There are other people.
Yes, thank you. All right. Now, Mark Baldridge, you said you're not new, but you haven't been on for a long time. You have something for us? You're muted, Mark.
Oh, sorry. Yes, I do. I can give you a quick synopsis of my history. I'll try to be kind of quick.
Very quick, please. Thank you.
Yeah. Okay, so I was diagnosed last August with prostate cancer, Gleason of 9. I had November last year, well, actually in 2020, I had prostatectomy with Dr. Lin at UW, and my tumor analysis revealed quite a few high risk effects like intraductal carcinoma, seminal vesicle invasion on both sides, extraprostatic extension, extensive perineural invasion. So anyway, 12 weeks after my prostatectomy, I had PSA of 0.6. It rose to 0.8. Shortly thereafter, I had my first Firmagon injection. And then shortly after that, I had the first of 37, well, I had 37 radiation treatments of my lymph nodes and my pelvic bed. My last PSA was undetectable. So my question for the group has to do with the duration of ADT. Like I said, I've had 11, as of yesterday, 11 Firmagon injections. And I'm getting a difference of opinions, talking to some very respected medical oncologists from Seattle Cancer Care Alliance, Virginia
Mark,
Mason.
we can cut you off there because I can tell you right now, I'm sure everybody agrees, standard of care is a minimum 18 to 24 months of ADT in a situation like yours, okay?
I'm not disagreeing. But, you know, I'll just mention Dr. Evan Yu and Dr. Song Zhao. They recommended 6 months because what they said is that the radiation likely was the curative aspect and the ADT played a supporting role. And so that was kind of their thought. But I think another thought is that, right, there could be very easily lingering microscopic prostate cancer still out there, non-detectable. And so I kind of feel like I don't know which way to go.
Recurrent Gleason 9 is 18 to 24 months, or even longer, some will say. You'll always find a difference of opinion. I'm not telling you that's right. I'm just saying that is the standard of care. You have to decide for yourself which path you want to go down. Anybody have any dissenting views on that, guys?
Why do you want to stay with Firmagon? It must be pretty uncomfortable.
It's not great, but I mean,
Peter, can we just stick on this topic of time first and then come back to the Firmagon afterwards? First of all, is there anyone else who's wrestled with this issue on here? Is there anyone else who's wondered how long should I do? I mean, we have people like Jim Ward, for example, and are there any men on here right now who have had follow-up radiation with hormone therapy and been unsure how long they want to stay on the hormone therapy?
Don Price did.
Don Price, go ahead, please.
Don Price. So the radiation oncologist said 6 months. The urologist said 18 months, and Dr. Schultz said 24 months. And so who the heck knows, right? So I went with 18 months, and I was on Firmagon that whole time. It was not uncomfortable until about the last 6 months, and then I was starting to have some things. And that's all I got to add. I mean, you know, that there is a difference of opinion, and you just got to pick something.
Is it right at your you get a tennis ball. Yeah, it's uncomfortable.
I've been on hormone therapy 3 times, and the first 2 times, Snuffy Myers was my oncologist, and the last time Mark Schulz was my oncologist, plus Charles Drake. And each time I was on for 12 to 15 months. They said, stay on the hormone therapy until you became undetectable for 2 months and then go off. And that's what I did.
Yeah, but Walter, I think this is slightly different. We're not really talking about intermittent and when to go back on. I think the issue here is how long should adjuvant therapy be? And the problem is that there's been a lot of studies around this. And I sent Mark the paper that Alan Adele published this past week. But that was really more focused on radiation plus adjuvant therapy as opposed to salvage therapy plus hormone therapy. And what happens is that we start sort of slicing things up in various ways. Is it the same if you have salvage therapy and you start getting the hormone therapy than if you start off with radiation and adjuvant therapy, like, for example, I did? I can just tell you a couple of little things that might be important. And that totally anecdotally, what we've seen here going back 10, 11 years or longer is that the guys that shirk on the hormone therapy tend to be the guys where there's recurrence. And this is anecdotal, okay? Especially where the seminal vesicle invasion, And it seems to me that with seminal vesicle invasion, when you do hormone therapy, you need to do it for minimum 12 months, if not 18 or even longer, 24. And whilst it's a pain at the time to do it, it's a drop in the ocean if it works. I did it for 28 months. And believe me, the last 12 months were really tough. But you know what? My disease hasn't come back. And I had locally advanced disease. It was out the prostate. Now, is that going to be true for everybody? And do we know for sure? We don't. So some oncologists will have an opinion you can get away with shorter. But what happens if you don't get away with it? Then you're on intermittent hormone therapy or hormone therapy for life. So you can say, okay, I'll stop right now. But the risk is it may not have nailed it. Now you can go for another 6 months. In my view, that increases your chances, but it's still not for sure. And I'm not a doctor. I know I would go for longer, but it may not, and it may come back anyway. So there's no magic bullet. I mean, I think that the best you can do is to seek more opinions than just Evan Yu. I don't know. I mean, I'm surprised that Evan Yu, knowing that you had introductory disease, I'm surprised that Evan Yu thought 6 months was enough, because we know, and I sent you the papers yesterday, we know that introductory disease is very likely to have spread to the, it's really likely to have spread to the lymph nodes. You know, another thing to do is to stop right now at 12 months, come off, see if your PSA rises. As soon as it rises above 0.5, 0.65, get yourself a PSMA scan and hop back onto the hormone therapy. But to me, you're taking risks by doing that, but it is a way to go if you want to try it. I mean, if you don't have, this is why, one of the reasons why we think it's so important to get these PSMA scans before you start treatment, so you know where the disease is. This is why we were telling Tom earlier on, get that PSMA scan before you start, because then you're in a better shape after you've had your treatment.
So say, Rick, how have you seen a link between more use of ADT and neuroendocrine? Have you seen any kind of link between that?
Yeah, so I think what you're asking, and we talked about this, we've talked about this at some length recently on here and elsewhere. The disease morphs, but I know that your concern is, well, if I come off of it now, then it's less likely to morph. But 12 months, I don't think is going to have that impact. Here's where we see that morphing link. And I'm going to let Herb have a shot at this too, because this is something that Herb has been facing himself. We see men who have been on second-line anti-androgens for 2 or 3 years. That's where we see the morphing, or 4 years. So if you've been on abiraterone for an extended period of time, if you've been on enzalutamide for an extended period of time, you tend to see that morphing. The other thing is, it's helpful to know if you have any genetic mutations, because if you have certain genetic mutations, they seem to be more common to people that morph. It may be the mutations rather than the ADT that are leading to the morphing. Herb, go ahead.
Well, I mean, I don't think there's any evidence, Rick, that this happens with just ADT. Right? I haven't seen that. I've seen it with pressure from the second line anti-androgens.
Right.
So to be honest, Mark, I think it's your decision, but if it were me, I would just go for the length and just have fewer worries in the future.
Mm-hmm.
You know, I mean, but if it's really that important to you to come off, then you should do it. But I think either way, it's your choice.
Yeah. Just maybe one last quick thing. I mean, I don't like ADT, but it's not that I'm trying to get off it. Trying to do the best thing. Is there any sentiment like, okay, I've had 12 months and on average, a person has, let's just say 3 years or 4 years of effectiveness. So let me not use all my bullets right now. Let me save them for later.
It's no. The
Is that
bottom
relevant?
line is, I don't think it is.
Okay.
Not at what you're taking, not with ADT. And, you know, it's not the worst thing in the world if it's keeping you alive. I mean, you got to think about that. I mean,
Yeah.
I don't see what's so bad about it. I'm on it now and it's, you know, I'm living.
Yeah. I mean, I can put up with the side effects. I mean, I can and I will if I really feel like that's the right thing for
But
right
Glenn,
now.
I think, you know, I think, Mark, you got to just make a decision. But Glenn, I think we're running out of time.
Yeah, I think so. We've got 10 guys to get to and in less than an hour.
May I add something? This is Ron Abbott. May I add something?
Go ahead, Ron, make it quick, please.
Yeah, I've had Phermagon a couple of times, and I think sometimes it's a matter of whether and how long the PSA goes undetectable. If you can hold it undetectable for a significant period of time while on Phermagon or ADT, then maybe that can inform you that it's okay to go off and monitor very closely the PSA to see if it rises with an ultrasensitive PSA test and get back on if there's any sign or add another drug or something.
All right, guys, we're going to move on. Herb, you're up.
Oh, okay. The saga continues. So the only good news is I had my first beginning of Provenge yesterday, and it went uneventfully. It wasn't any big deal at all. I sat there for 2.5 hours while they took the blood out, took out the antigen presenting cells, and then shoved the blood back in. But the downside is that, so Rick and others have said, and we, you know, do some more genetic testing. So I did a liquid biopsy with FMI, Foundation Medicine, and it came back that the tumor has in fact developed mutations that weren't there initially, and not good ones. ATM, PTEN, P53 is still there, and then an interesting one in the androgen receptor. So I shared this Foundation Medicine report with my oncologist, because it was ordered by Hopkins. I sent it to NIH. The NIH genetics people looked it over, and they recommended Enzoludamide at this point. Now, I have not, and what I have been reading about, and this is kind of gets technical, but the mutation of the androgen receptor that I have is resistant to Enzoludamide, according to the papers, but not resistant to darolutamide. So I thought, let's try darolutamide. Well, my Hopkins oncologist says, yeah, we should do it after you get finished with Provenge. My NIH oncologist says, well, we should try out Enzoludamide now. So then the question is there any interaction? And so I found a paper by Larry Fong that says there's no interaction with abiraterone and CYP or Provenge. But there isn't any paper on enzalutamide. So I wrote to Larry, and he wrote back almost immediately saying there's no interaction with enzalutamide, but there's no data about darolutamide. So the question I posed to the group is, if you were me and there's no data and I'm in the middle of Provenge, would you wait till I'm done with Provenge to do the DARA, or would you say, let's take the chance and do it simultaneously?
If it were me, Herb, I would take the chance and do it immediately. If there's no interaction with Abby or Enza, I don't see why there would be one with Darrow. And I don't even know why they're proposing enzalutamide when we already know that androgen receptor mutation you have causes enzalutamide resistance, or it's seen with enzalutamide resistance. And some pre-clinical data showing that darolutamide is effective in those mutations.
Right. I think the NIH proposed enzalutamide, and this was a later in the day correspondence, because darolutamide is not on their formulary. They can't give it to me.
Yeah.
But she said, check with the Hopkins guy and see if he'll give it to you sooner. So, but, so the question is, Len, you would take it. I think I would too, because I don't see I think the probability is low.
Yeah. Anybody else want to chime in on this?
My guess, Herb, is that by the time you got the darolutamide, you'd be done with the Provenge. It's only a couple more weeks, right?
Oh, it's 6 weeks.
Oh, 6 weeks. Okay, but still takes a while to get it approved and all that stuff. You might be just about done with it. I would take it. I would take it concurrently. I would worry about.
Herb, it's 4 weeks. It's not 6 weeks. It's 4 weeks.
It's 4 weeks. It's 3 injections 2 weeks apart. You're right.
Right. It's 4 weeks. And I think that Peter's made a really good point. You may not get it in time. I would start asking for it now. We know that it may be that the androgen receptor mutation that you showed, T878A, favors darolutamide. And I'd be trying to get darolutamide, if it were me, I'd be trying to get it as soon as I could. I'm not sure whether I would stop the Abby or not. That's got a lot of pros and cons, but I certainly would be looking to get the darolutamide as quickly as I could.
Let's go back to the stop Abby. So another paper, so this gets really technical, guys, and I don't want to bore you, but when you have Abby, and Rick talks about how the tumor morphs, right? When you have Abby and ADT, you have an androgen receptor that's not happy. It's not getting activated. It's an unhappy receptor. And so it looks for a way to become happy. This is kind of an allegorical, but one way it becomes happier is it turns out it normally has a low affinity for progesterone in addition to testosterone. And Abby raises your progesterone level. And so the receptor says, I'm going to morph, I'm going to mutate, so I become sensitive to progesterone. And that's what this is. The T878A mutation is sensitive to progesterone. And since Abby raises progesterone, I decided, let's stop the Abby. So that's the story. But of course, PSA is still going up, and we're going to have to do something else next. What that is, we don't know. So Rick, here's another piece of news. My good friend's daughter is head of global oncology at Roche in Basel.
Right, you've mentioned that.
And she says that she expects that lutetium will be approved very soon.
Well, I think we all expect it'll be approved very soon. The question is, how soon is very soon?
Right. Right.
And we don't know. I mean, you know, the people at Novartis told me they're hoping they can bring it back online in the middle of February, which is only 2 weeks away now, 2 or 3 weeks away. So we agree. But I think, Herb, I mean, I'm just very interested in one thing I'd like to get out of this group for Herb. Is anybody in the group tonight? Well, I know there's one person in the group tonight who has TP53 and PTEN. And I want to try and give Herb some comfort that TP53 and PTEN, you know, are not going to stop his ability to treat the disease. Anybody want to talk about TP53 and PTEN?
Yes, Rick, Joe Blanchett here. I have both of those, and I want to straight from the mouth of Anton Arakis. He says the three worst ones that you could have are RB1, TP53, and PTEN. But he says, when I have a patient with RB1, my heart sinks because I know I cannot help him. But I can help the guys with TP53 and PTEN. So
thank you, Joe. Thank you.
So, but thanks, Joel, because there's no RB1.
Good, very good.
Retinoblastoma. No. But you know, the guys, I will say, and it's come up before, and Rick has convinced me, you got to do this biopsy periodically to keep up with the tumor. I mean, I think we look, you know, if we didn't do this FMI biopsy, I wouldn't have this data. And I think the data are helpful.
Now, this does raise another point. I know we're running late, but this raises another important point for everybody on this call. If you get a FMI biopsy, make sure you get a copy of it yourself.
Oh yeah.
When the biopsy gets ordered, when the liquid sample is sent off for the analysis, tell your doctor or call FMI and tell them you want a copy yourself. Sometimes the doctors don't send you a copy, and sometimes you don't know what's on there, and sometimes the doctors don't read it properly, and sometimes the doctors don't discuss it with you, as Herb and I found out last week.
Right. What I found out was the report came in. He must have given it to his nurse practitioner, and she scanned the first page. And that's all I saw. And then I went to the FMI website where they show you what a typical report looks like of 37 pages. And I said, where the fuck is the rest of this report? And it turns out it was a one phone call to FMI, and 20 minutes later, an email came with it. But that sort of pissed me off.
Right. And that's a great lesson for everybody, because we encourage you to get these. And even if you don't understand what you're reading, you'll call one of us. We'll help you out to read it. But then you keep your doctor honest. And it's so important to keep that doctor honest.
Okay, Herb, I'm glad you were a strong advocate for yourself there. I don't believe you said, where the fuck is the report? I'm sure you used more discreet language. But okay, thanks. And okay with you if we move on?
Yeah, move on.
All right, Carl Foreman, you're up.
Okay, boy, I have to talk fast. So the information I have to share right now is very raw, is very up to date. Earlier today, I had my final meeting with Dr. Tagawa in regards to my clinical trial. 22 weeks or 24 weeks into this trial. And I had scans as well as blood work yesterday, and I met with Tagawa today. And bottom line is that he says it's not going where we want it to go, and we're going to have to stop the trial. So I am being taken off of Xtandi, which I've been on every day for the past 24 months. Not 24 months, 24 weeks. And also the Keytruda, which I was having infusions every 6 weeks. I was scheduled to have that today. I actually went into the room where I was sitting at the chair to have it started. And then they said, well, the doctor wants to see you upstairs. And So anyway, that's what has happened. And he said the next step from what he sees is that I need to go on to chemo. I also contacted my doctor at CINJ, Dr. Soraya. I didn't actually speak to him. I was communicating back and forth with him. I sent him copies of the scan reports. And also I do have an appointment with him this Monday. I know in many previous conversations here, there has been a tremendous amount of discussion about which type of chemo would I should be considering, and because of the fact I am also BRCA2 positive. So I had figured that it was kind of a no-brainer, or maybe it's more than that, but cabazitaxel with carboplatin seems to be my next step. Tagawa wasn't too thrilled about that kind of a combination. He thought that I should start with docetaxel, and he said cabazitaxel is potentially more, has more side effects. And he wasn't familiar enough with combining it with carboplatin other than, well, if you're combining 2 chemo drugs, that means you're going to have more side effects. And so that's what his guidance was. And as I said, I don't have that guidance yet from Dr. Soraya. So my disease is progressing. My PSA is continuing to rise. It hasn't progressed from the scans. It hasn't progressed a tremendous amount, but it's progressed enough since the last scans that they're telling me that we need to move on to the next step. So I'm a little bit I'm in a little bit of state of shock right now because I wasn't expecting that today.
Well, Carl, I'm sure we're all very sorry to hear that the trial didn't work for you. For what it's worth, all of us appreciate the fact that you entered this clinical trial. You know, it helps all of us eventually, whether the trial is a success or not, and particularly with the new type of therapy that you were undergoing, the immune checkpoint inhibitor, Keytruda. For those on the call who are new and may not know what that is, it enhances your immune system. Sometimes it works like magic, but more often than not, it falls short, particularly in prostate cancer patients. There's some success in other cancers. But anyway, everyone's experience helps all of us, and we appreciate you for that. And I wish you lots of luck with the chemo. Have you decided if you're just going to go with docetaxel?
No, you know, I'm going to have my discussion with Soraya from my main oncologist at the Cancer Institute.
Yeah.
On Monday.
Yeah. What about anybody talking about another genetic analysis? As we just heard from Herb, he had some new and different mutations that might help you.
Right. No, other than what you're saying here tonight. No.
Carl, this is Peter. Give me a call because you know I went through docetaxel carboplatin last year. I'll be glad to talk to you about my experience and side effects.
Okay, great. Thanks.
Have you been on a PARP inhibitor yet?
Sure have. I was on it for close to 2 years, and it was very successful for almost that entire time until it ran its course. And it had my PSA is undetectable since I'm BRCA2 positive. And but as far as any follow-up breakthrough therapies from for those of us who are BRCA2 positive. It's like, you know, that there's not that I found anything out there.
So, Carl, there are a number of papers that you probably should familiarize yourself with before next you meet on Monday that suggest that the right treatment for somebody with the profile that you have, the existing mutations that we're aware of, who knows what we're not aware of, that support this mixture of a taxane and a platinum. Now, none of us on this call, I think, are capable of saying which taxane, should it be docetaxel or cabazitaxel, and which platinum-based drug, should it be carboplatin or one of the others. But we know that that's the right way to go. Ken Anderson's doc, Paul Korn, has been the primary author on a couple of those papers. Andrea Hartstark has been another author on those papers. And Dr. F. Stathiou, has also been an author on those papers. And, you know, I find it a little surprising that Tagawa isn't right on that. I mean, he must know these are pretty well-known papers. They're not obscure papers. So I think I might have sent them to Herb recently. I've got them somewhere. I'll try and find them whilst other people are talking and put them in the chat window for you. But these are very important indicators for me. If it was me, I'd be wanting to do some combination of taxane and platinum. And you know, I think it's going to make a big difference, and I think it's long overdue for you. And we really, really hope that this will make the breakthrough. Oh, I know who I sent him to. I sent him to Steve. I'll put him right in. I just remembered. I sent them to Steve Sapp last week, so I know exactly where to find them. I'll put these two links in there for you. It wasn't
Carl, this is Brian Davenport. I'm taking cabazitaxel and carboplatin right now. I'm just had my 5th cycle every 3 weeks, and I've had next to no side effects as a result. Before I started this, the medical oncologist called and said, you know, I'm a little concerned that you realize that these are very powerful and you may experience side effects. But my quarterback, which I'm grateful to this group for getting me hooked up with my GU oncologist at Duke, said I had almost 12 months where the cancer was not being successfully treated, and we didn't need to mess around any longer. We needed to go after it. And my quality of life had been very good up until, and it still is, but is based on the fact that I was healthy and that in terms of being able to play golf and do other things, he recommended going for that combination of drugs. And it's had a significant impact on reducing my PSA level down from 10.9 to 0.25, and
wow.
CEA numbers from 840 down to 330. It's still high, but coming in the right direction. And I'm going to go for a total of 8 cycles, 3-week cycles, and then redo scans at that point. And I'm kind of sharing what I was going to share tonight. After that, you know, I hope that it does like it did the first time when I was on docetaxel and Lupron. I had about 20 months of remission. I'm hoping that after 8 weeks, 8 cycles rather, of the carboplatin and the cabazitaxel, that it goes into some kind of remission again. And then if somewhere downstream, the lutetium again is when the chemo no longer is effective, is the direction I'm headed also. I've had a PSMA that looks like I'm a candidate for using that. But so I, again, I was in a trial, abiraterone and enzoludamide did not work for me. So I had almost 12 months of steady, slow growth. And my quarterback doctor, Dr. George at Duke, said it was time to really go after the cancer. And so far, it's working very well.
Great to hear.
That's great news.
Yeah.
That is really good news, especially because your disease also was a very, very strange and morphed type of disease to treat, Brian. And that you've responded to that is really positive. And Carl, I hope it's an encouragement to you. Brian's playing golf whilst he's taking carboplatin and taxane, and he looks terrific there. I mean, I know that doesn't mean he feels terrific, but he looks good.
The only problem I had, Rick, is at Walter Reed, the elevators were out on the parking garage, and I had to walk up 6 flights of stairs. And I had to stop at the 3rd level and the 5th level on my way up. Other than that,
We'll forgive you.
Good.
We'll forgive you for that. God bless you God bless you.
yeah. So next February is my the first week of February is 3 years from first diagnosis with a Gleason of 10 and a PSA of 300. And so that's the process I've been on. And Lynn, since I was able to share that, I don't need any more time tonight.
Well, okay, Brian, that was a great report. Thank you so much for that. I'm sure it gives Carl some encouragement. And another bit of encouragement with regard to cabazitaxel, in case you didn't already know, Carl, Steve Zaft, who Rick just referenced, he's completed 6 cycles of cabazitaxel and he's tolerated it incredibly well. Hasn't lost his hair, hasn't had any neuropathy, hasn't had any bone marrow suppression. So I'm not sure why, I forget which one of your doctors said
Tagawa,
Tagawa said that cabazitaxel, he's worried about side effects. I mean, docetaxel definitely has more side effects than cabazitaxel. Just
I thought.
And Carl, I just put those 2 links into the chat window for you.
I see them.
And you'll talk to Peter. Peter floated through the first 4 or 5. It caught up with him eventually, as he'll tell you. But the sooner you get this stuff into you, I'm really hopeful we're going to see the same sort of response that Brian has gotten. Truly hopeful, and Peter for that matter.
Yeah, Carl, I had more side effects from the docetaxel than I have from this combination, and so I'm been very pleased with it. There is a little fatigue, but nothing. I don't know if it's a lack of exercise on my part that's leading to part of that, but overall, I'm doing very well. And if it weren't 40 degrees outside, I'd be out playing golf.
Brian, are you on ADT as well while you're going through this?
Yes.
ADT.
Yeah.
Lupron.
Oh, Lupron, right. I'm still have the Lupron, and they are continuing me on that. I asked them about whether I needed to stop it or not, and they said we need to continue it.
Yeah, I stayed on Lupron and darolutamide all the way through mine too.
Yeah,
So
no,
on the positive side, I welcome the fact that I don't have to commute from Central New Jersey into Manhattan for all of these meetings I've had with Tagawa, and also to be off the Enzoludamide with whatever side effects I've been experiencing with that.
Yeah. So will they continue you on any other form of hormone therapy, Carl, or you don't know yet?
Don't know yet.
Okay.
Thank you.
Okay, we look forward to your ongoing report.
Okay.
Brian already gave us his testimony for tonight. Does anyone have questions for Brian before we move on? All right. Well, thanks again, Brian. Appreciate that. Let's move now to Bob Smith. If he's still with us. Yes, he is.
I'm here. Yeah. So last time I was with this group, which was I think about a month ago, I reported that my PSA went from 10 to 14. And then the most recent PSA in 40 days jumped from 14 to 44. So even last time, you guys were advising me, that we needed to find another therapy. I've been on Abby, and they told me Lupron for life. So my doctors I have a doctor here in Hawaii, Dr. Kearns rather, and also Handria Hardstark in San Francisco, and they both suggested Radium 223. So they are busy preparing that to come, and so I'd be curious to know if others have been through the Radium 223 and what their impression was and what you think of it in my situation.
Bob, before we open it up to the group, do you have any metastases that are not in your bones, like any lymph node metastases or soft tissue?
The recent CT showed no visceral metastases, but a whole slew of them that were bone.
Okay, well, Radium 223 is a reasonable choice for strictly bone mets, particularly while we're all waiting for lutetium. So guys, anyone want to comment to Bob?
So how unusual is having a PSA jump like I did from 14 to 44 in 40 days? Is that something? Is this a new world record? Or is it
so Bob, let me ask another question, Bob. Have you had any scans lately?
Yeah, I just, let me see, what's the date? Almost 2 weeks ago, I had a bone scan and the two CTs, whole body and pelvic.
So did the bone scan show significant changes from your previous scan?
Yes, it did. I've got a lot of fractures that are either healing or have healed and that show up on the bone scans. Sometimes the radiologists think those are cancer. But I went from about 3 to 6 up to, I'm guessing, 20 or 30 bone mets.
So Bob, are you taking a bone protective agent?
They're going to start that for me soon. I need to see the dentist first.
Right, but I would have started sooner if it were, which is what they did for me from the get-go with bone mets. But you need to have that in place before radium.
Yes, I understand.
How long have you been on Abby?
Probably 6, 7 months. And it seemed to help first, slowed down the PSA, but then the PSA just started taking off.
Yeah.
So,
So,
Bob, have you done genetic test?
Herb, hold on a minute. I think I have a note that Bob Smith was on Xgeva. Have you been getting Xgeva, Bob?
What? Well, that's the brand name for something. What's the generic?
That's a bone strengthener. That's
Oh.
a bone strengthener.
No, I haven't been on any bone strengtheners.
Okay, because I have a note that you told us you were taking Lupron, Abi, and Xgeva. So you might just want to check your own records.
Yeah, I'd know if I was taking something besides those two. Besides the Lupron.
Denosumab is the generic.
I'm wondering if it's another Bob Smith. That sometimes happens to me. Like in high school, I got the other Bob Smith's grades.
No, it's not another Bob Smith. It's the Hawaii Bob Smith, and I have the notes right here. So when you go in to get your Lupron injections, do you only just get one shot, or do you sometimes get two shots?
Just the one each time. The last one was a 6-month shot.
Okay.
Bob, can they do the nuclear medicine at Kona? Can they do the treatment in Kona?
No, I don't think they can. I've looked around, and one of the receptionists in the imaging department at the hospital here, Kona Community Hospital, said, "Oh yeah, we do that," but I'm thinking she didn't know what she was talking about. I can't find anything on the website. I can't even find any nuclear medicine doctors on the whole island. So I think I'm going to Honolulu.
I had a buddy here on Maui that did it here at the hospitals, and Kaiser's running the hospital here, so you might be able to get it on Maui rather than going to Oahu. But I don't know.
It's about the same. Actually, there are more flights to Oahu. Yeah, it's another 15 minutes maybe on the plane, but I'll take a look at that anyway.
Yeah, I could help you out. I could pick you up and take you there if you wanted it, if you need help.
Oh, well, thank you.
So Bob,
how old are you, Bob? Bob, how old are you?
I'll be 78 in April.
Okay, did they discuss chemotherapy at all with you?
They did not. I'm aware that that's in my future sometime, but both my doc here and Harstark thought that the RA-223 would be best at this point. No mention of docetaxel or anything.
Mm-hmm. Yeah, the other thing I think I would push for, do you know if you had an Axumin scan, Bob?
No, I know I haven't. I had between my prostatectomy and which was November 18, and lymphadenectomy, and I think it was April of 19. I had a PSMA gallium-68 scan at UCLA.
Okay, but
That was
and how long ago was that?
That was early, winter of 19.
Okay, and when you did that back then, did it show any disease in any soft tissue anywhere?
Just in one iliac lymph node, and then when I had the lymphadenectomy, that was indeed PCA, and that turned up 2 others. He removed 15.
My concern would be this, because you have a history of disease in the lymph nodes, that's in soft tissue. And I think before I committed to doing the radium treatment, I'd want to know if there was anything in any of the soft tissue right now. And the only way to know that is to do either another PSMA scan or an Adjuvant scan. And your PSA is high enough that you could see it on an Adjuvant scan. And I would be asking Kaiser and saying, look, this is great. I'm ready to do the radium, but I just want to be sure I don't have any soft tissue disease, which is where Herb started with all of this. And I want to do an Adjuvant scan or a gallium scan first.
Okay, I mentioned those, or at least the gallium, to both docs, including Harsark, and they both said it doesn't make any difference as to what we would recommend for your treatment.
Well, I would go back to Hartstock and say, Doc, what if I've got soft tissue metastasis?
Well,
am I still a candidate? If I've got soft tissue metastasis, am I still a candidate for radium-223?
Well, what's the downside if I do have some small visceral mets that weren't picked up on the CT? What's?
Herb, you want to answer that?
The radium only attacks the bone,
right.
Bob. It doesn't affect anything else.
Yeah. So meanwhile,
so you really, I mean, if you have any disease outside of the bone, Bob, you're still not going to be treating it.
Okay. So I've read some things about Enzoludamide plus radium-223. Any opinions on that?
Well, it's certainly, once again, it's not going to take you out of the bone.
Oh.
And the likelihood the enzalutamide is going to have an impact after abiraterone is not very high, about 8%. So yes, it might be an effective thing to do if you hadn't had abiraterone, but not in the situation where you've already been through abiraterone.
Okay.
And then finally, I'm going to say what I said before, Bob. Have you had recent genetic testing?
No, not recent. They mentioned that last time I Zoomed with them, and they want to do that because they realize that the cancer morphs.
So get them to order FMI. It's 2 units that you can do locally.
Yeah. Okay.
All right, guys, I think we better move on.
Let's just summarize. I think the takeaway for you, Bob, is get some FMI testing and push to get some sort of an Adjuvant or PSMA scan to ascertain exactly where the cancer is right now.
Okay.
And make sure you get put on Xgeva. Definitely need a bone strengthening agent with all your bone mets.
Yeah. I think they're recommending something Zometa. Something.
Right. That's it. That's good enough.
Good enough, I guess. Okay.
Thank you.
Thank you, Bob. Let's see. How about we go to Jimmy Greenfield? What you got, Jimmy?
I'm going to pass. I don't think it's worthy of the call. I'll try another night.
Okay, Jim. Thank you.
You're welcome.
How about Chick Lindsay?
Hi, can you hear me okay?
Yes, loud and clear.
Okay, thanks. I'd like to update you on my direction with treatment. Thanks to Herb and Rick, I was able to heard about Dr. Antonarakis in Minneapolis, and I saw him a week ago yesterday, and he's recommending that I get a PET PSMA scan, which will be on Thursday, just the day after tomorrow. I believe that's what it is, CT machine. Anyway, And then I'll meet with his recommended radiologist next Tuesday, a week from today, who will tell me what they see on the scan. And then apparently there'll be 30 courses of the radiation treatment. And he only had 2 data points when I walked into that appointment to find out about the doubling of the PSA, which he calculated to be 11 months. And he said before I leave today, he wanted me to get another another PSA test, which then revealed that the doubling time was 11 months. It was 11 months, and then now the doubling time is 8 months. So by that calculation, he reckons that it's a high risk cancer, as he called it. The PSA, actually, the only 3 data points are 0.18, 0.20, and that was the end of December, just about 4 weeks ago. And then 3 weeks later, 0.24. So anyway, he's thinking that unless the radiologist wants another test of some kind, that I'll start these radiation treatments. And then he also said he also wants me to do ADT for 6 months after I finish the radiation. And so I haven't gotten a second opinion. The man comes highly recommended, and I'm feeling good about the team. I'm feeling good about the support that's come down just in 6 days from University of Minnesota Cancer Center there. In terms of getting the appointment set up and just the communications, I've been really actually quite pleased. Now, however, before I came on the call today, I talked to a fellow, just a guy I know, hadn't seen for a while. So he's got me a little bit, oh yeah, no, I don't know about radiation or I had the prostatectomy too, and this man was telling me, I didn't. So I'm hearing, a little bit of, what's the word? A little bit of static, He said this man went through HIFU ultrasound to control his cancer with a Dr. Cianti in Sarasota, Florida. Anyway, so I guess my question is, first of all, any responses to what's set up here for me as far as with Dr. Antonarakis?
Well, I think it's easier for us to respond to Dr. Cianti. Len?
Yeah.
Is he in jail? Is he in jail yet or not?
Okay.
No, they're investigating him for traces of snake oil. So, Chick, you said you already had a prostatectomy?
Yes, I did. 2 years ago.
Yeah, so
2 years ago.
it's meaningless for you. That's not an option. Yeah.
Okay.
That's only for people who still have a prostate and maybe they think they can just excise a small bit of the prostate gland.
Okay.
So friend, don't listen to that guy anymore, your friend.
Thank you. Thank you. Thank you so much for that, because I don't. Yeah. Okay. Thank you. I hear you.
I think it's good for taking all the money out of your wallet, but that's about it.
Okay. Yeah. He did indicate that the insurance didn't pay for it 5 years ago. So. Anyway, okay.
So do you mind if I comment? Because it sounds like you and I are somewhat in the same boat. I had an RP back in 2013, and I was clean for almost 9 years. And then my PSA started climbing, and very slowly, no doubling or anything like that. It did get to 0.28, and I went and got a Psma scan, and of course, it didn't show anything. I went and got several opinions. I went to 2 doctors at University of Chicago, one at Northwestern, and they thought it was, microscopic. Because of the fact that the PSA was rising very, very slowly, there was something there. There was no lesion anywhere that was detectable, but
micrometastatic, as they said. So when it got to 0.31, and again, I talked to two of the doctors, Stadler and Lau, who's the radiation guy there, and one guy at Northwestern, and actually a guy here locally. And they said, if you want to go ahead with the radiation, fine. You could let this go, and maybe in 10 years, it may not get that bad at all. But if you want to go ahead and knock it out and be aggressive and do it, and I said, that's what I'd like to do. So, they salvage radiation was what they recommended. I asked them about the hormone therapy or ADT or, whatever. And all three doctors told me anything under 0.5, they felt, and this is their opinion, that absolutely, they felt that it didn't offer anything to the treatment, and they recommended that not to do it, and just to go ahead with the salvage radiation, which I did, and I finished it not too long ago. My radiation guy said, what we're expecting is that we don't see an increase, or we see like about a 5 to 10% drop. I actually dropped almost over 90%. I went from 0.31 to 0.024. So my doctor was just thrilled. He says that rarely do I see a drop like that. So that's my story. And again, like I said, it sounds similar to what you're looking at, but that's just what happened to me recently.
Yep. Bruce, thank you for sharing that, for sure. Dr. Antonarakis did say that with his PET scan, I think he said something like only maybe a 10% chance that it will be that with the level of PSA I have that any cancer would be detected. He also said, however, well, he just regarding to the radiation, he said, I feel like I would like to have you, even if I can't get you in for a PET scan, if my radiologist would go at it anyway without the PET scan, I'd have him do that. It turns out that I am able to get the PET scan ahead of the. I guess his radiologist definitely wants to have the scan to see if there is a target he can go at. As far as the ADT therapy, I guess my takeaway from my memory from the conversation last week was that with my post-surgical report, it was a Gleason 4+3 and EPE, extraprostatic extension. That fits the Johns Hopkins protocol, was just what he told me. And
Dr. Vanderweel at Northwestern said, well, he says, that's just standard procedure. And when I went to talk to the two guys at University of Chicago, they said, you're going to hear that yes, that's the standard, and that's what everybody just recommends. You heard Rick mention earlier on that if you don't want to do that, maybe you're rolling the dice. But when I talked to the two Dr. Stadler and Dr. Lau at University of Chicago, they just said, I can't recommend that to you because at under 0.5, I just don't see it offering anything for you. And then because I lived an hour and a half away, they both recommended a radiation guy here in my neighborhood who they recommended many times before. And I met with him and I just asked him, and he says, it's my opinion as well. He says, if you over 0.5, he says, absolutely, or close to 0.5. But he says at 0.31, and the way it's been growing so slowly, he says, I just don't see where it's going to benefit you. So that's my story.
Yeah, thank you. My wife asked in the meeting, so these little cells, even after the prostatectomy and even no other extension, they just lay around so small. And he said, well, he said, I've done 3 studies where with different medications, with drugs to try to, I'm sorry, I'm not sure exactly what my memory, but some way to determine how to kill those just minute cells, but we have not been able to figure it out. But then he turned and he told the story about, the 2 urologists he knows of, 2 urologists who have won Nobel Prizes, and he cited the guy who figured out that the androgen deprivation therapy actually delivers the coup de grace for many men, I guess, at that level.
Radiation and ADT do work synergistically, Chick.
Could you say it again? I'm sorry, say it again? Then?
Radiation therapy with ADT, they work together synergistically. So,
Okay.
yeah, you improve your chances of never having further treatment if you add the ADT to your radiation.
And
yeah,
just
thank you. He said, actually.
One last
sorry.
question, Chick. One
Okay,
last
okay.
question for you.
Yeah.
How did you like Dr. Antanarakis?
I liked him. I think I was so impressed with his obvious thorough knowledge of my record. I mean, I walked in and he was telling me everything that I could. He knew everything, and in fact, he knew about my brother's history. I must have left something in my own medical record about my brother who has cancer as well, prostate cancer. So anyway, I was very impressed. Thank you. Just very impressed. I think he was just, thorough, and he had 2 other people with him, a fellow guy on a fellowship and another guy in radiology, and young guys, but I liked how he interacted with them as well. So
Good. Okay.
I would say one more thing too, just a remark to what Len said. He was really, really clear. He said time is of the essence because we're going to approach this with curative intent as opposed to quality of life intent. So he said there's a chance because it's small enough, presumably small enough that that they'll be maybe knock it out with this treatment, this treatment plan.
Yep.
Anyway,
thank you. All right. Good luck, Chick.
Yeah, thank you.
Let's go on to Joel Blanchett.
Yes, thank you, Len. I've been AWOL for the past 2 weeks. I've been in sunny Florida trying to sun myself, but I didn't see much sun. I even got 46 degrees yesterday morning when I got up and went to breakfast. So anyway, I'm back home now and I'm back in operation. Dr. Eblin, my radiation oncologist, gave me a call when I was in Florida and said, hey, we're trying to plan your treatment for SBRT. I was supposed to get my first SBRT out of 5 tomorrow. That's been postponed a week now because he says your 5 scans that I have in front of me all cut out where your disease is. He says you've had a CT scan, a bone scan, 2 MRIs, and a PSMA PET scan, and they all cut out at the end of your spine because all these doctors have been ordering spinal scans and not head scans. He says, I need to see what's going on your head bone. And he says, I only see 2/3 of your disease, and I want to make sure I treat all of your disease. So today I went to take another MRI, and now they took a brain MRI, so that is going to give them the occipital condyle bone on my right neck. So hopefully Dr. Eblin, starting next week, will be able to give me the first treatment of SBRT.
Okay.
That's just an update.
Yeah, thanks for the update, Joe. Appreciate it. Let's see. I've got.
And we should add, by the way, for Chick's benefit, that Joel is also a patient of Dr. Antanarakis and has followed him all the way from the Maryland, Virginia area to Minnesota, correct? Joel?
Yes, that's correct. Yes, and I have more to offer on him in about a week from now, because John Hopkins has a new treatment plan for new guys who just got prostate cancer, and he will see, as long as you're willing to drive from Virginia to Maryland, he will see you in Maryland via teleconferencing. So that's a piece of good news.
Okay.
Ron Abbott, are you still with us? Ron? Going once? Oh, yeah, he's still with us. Ron, you're up. I see your microphone is on. Well, maybe he stepped away. John Christopherson.
Here I am. I finally got to the mute off. Sorry. I was unloading
Ron,
a
go ahead.
bunch of groceries. It's after 5 o'clock. Do you still have time?
Yeah, go ahead.
Okay, real quickly. I got a Polarify scan in mid-December, and I've got a MET and T7 rib in my back that's butted up against the spine, a couple centimeters or so, as well as, and that was a SUV max of 22, and a small MET in my T9 vertebra, and just an SUV max of about 3. And I'm considering radiation therapy, some kind of focal therapy to these, and I would like to know if anybody knows of a focal therapy to bone for this kind of a case other than external beam radiation therapy or cryotherapy, which probably doesn't apply to me.
Well, I know we have heard, I think it was Les Sheldrup who had cryotherapy to a spinal MET. Is Les on the call?
Yes, he is, and yes, there were 2 spots on my spine that they used cryoablation on.
And that
So
worked?
actually, the vertebrae, they were able to do cryotherapy without risk to the spinal cord?
There was one of them that they were a little concerned about, but they said that they would use caution, and things turned out fine.
Well, I'll be talking. I've got appointments with medical oncologists the next couple of days, and I'll be talking with them. And I've already had appointments with 3 different radiation oncologists. And of course, they all want to offer their services to me. I've been on Argovix for since December 17th. That's when I had the Polarify PET scan. And so I'm hoping I'm still oligometastatic and can terminate these things and not have a recurrence, but I know it's going to be a long-term management probably.
Why are you averse to IMRT, Ron?
I'm not adverse to it. I've already had 1 radiation therapy to an obturator lymph node, and I just kind of adverse to radiation in general if I can avoid it. But I think it's the proper course of action in this case because it's a relatively small volume and it's 5 treatments. 1 week of treatments is what's being recommended, SBRT. Or I also consulted with Dr. Rossi at the California Proton Center and Dr. Shrazi at Genesis Prostate Cancer about CyberKnife, radiosurgery techniques, and I'm kind of torn between the different varieties of radiation therapy right now.
You know, I know that radiating the ribs can be difficult because it's such a small target. It may be more possible with SBRT. Some of the guys on the call maybe have more information, more thoughts on that, know a lot more than I do. But you know, I would not be too concerned about doing RT at this point in time. It's probably a really good way to go.
Yeah, I think it's better to do it than not do it. It's,
Agreed.
Otherwise, I'd be on long-term ADT, which I don't really want to do. I'm going to do a few months of ADT before the radiation therapy and at least 6 months, maybe more afterwards, see how it goes with my PSA.
Yeah. I mean, now is sort of the sweet spot to try and get it. You don't want it to go too far.
Yeah,
So
I was also thinking that if the PSA starts rising again, maybe chemotherapy would be in order to take advantage of low tumor volume and try to hit it hard with something and knock out the remainder if possible. Would you agree with that kind of a strategy possible?
Well, you don't have the volume really to warrant it, but that's a Schultz type of approach. I think that's probably what Dr. Schultz would suggest. If you're not averse to it, you could try it, but I don't think that it's not going to take away or exempt you from androgen deprivation therapy. At some point, androgen deprivation therapy is in your future. Whether it's just for short or long periods of time, I think it's there.
Yeah, I've been on Orgovix for about 5 weeks now.
Right. I
So
wondered if
I
you
went
got
on
it.
it
I know
immediately
you.
after the Verify.
Yeah, I had a note that you'd requested it, but I didn't know that you got it. But yeah, I mean, I would say if it were me, I'd try the spot radiation. It's the least invasive. It's going to have the least number of side effects, and so I would prefer that, and then see where you go, and then just go one step at a time.
Okay, thank you. I also wanted to ask if everyone was aware of the excellent presentation that Dr. Kwan did for the PCRI on December 17th, I think was the date of it. It's like a 3-part series on do-it-yourself battle plan for conquering prostate cancer. It's really excellent presentation if you haven't watched it.
And who did it? Larry Fong, did you say?
PCRI.org. It's Dr. Kwan from the Mayo Clinic.
Oh, Dr. Kwan. Okay. No comment. We'll let everybody decide whether they like it or they don't like it. But
I watched it. I thought it was good.
I bet you did. I knew there'd be one fan in this room. Did anybody? I'm curious if anyone else watched it. Len, did you watch it?
I did not, but I had planned on watching it when I have time to.
Okay.
I think he's always.
Thank you for the recommendation.
He's always entertaining.
Okay, yeah, he's always entertaining. That's absolutely right.
This is better than his usual. This is one of his best presentations, I think.
Okay, Ron, good luck. And we're going to see if John Christofferson is still with us. I don't see his icon. John, speak up, please. Or else we will move to Gary Peters.
Hi, Len. I'll pass for tonight.
Okay, Gary. Sorry we couldn't get to you sooner. What about Fred Stiers? Is Fred still with us? Hi, yeah, there he is. You're muted, Fred.
Yeah, I figured I would present my set of questions at the next meeting as well.
Okay. I'm sorry, I forgot. Were you new?
I've been on about 2 meetings in the past.
Okay. All right. So I guess we'll entertain your questions, and Gary's at our next session, whenever that is, Rick.
Okay, so we can talk about that. I'm going to share this correspondence I'm having with Carl Foreman in the chat window, because he says that Dr. Tagawa is of the opinion that lutetium 177 will not be a game changer because it will help some but not others. I think what we would say, and we've seen it in the trials, that it helps pretty large number of people. Is it going to help everybody? No, because about 20% of people are not PSMA avid, as I understand it. Is that the right number, Len? 20% or Herb?
I think that's about right.
It's close.
But you know, the other more important issue, Rick, is well, maybe it's not more important, but equally important, is that they should be doing FDG scans to see. Some people will have positive PSMA scans, but they'll also have positive FDG scans that don't light up with PSMA, and they are not real candidates.
Right. So, you know, if you're not but those are the folks that aren't expressing PSMA fully. And we know that those guys are not going to get it. But if you were asking me, I would say, and I did say, yeah, I think it is a game changer, because for those people who express PSMA, it's going to be a really significant treatment. But for those who don't, I feel it's, you know, it won't help them that much. But I'm surprised that Tagawa doesn't feel, with all the work he's been doing, that it's not a game changer. That's a bit of a shocker to me. Well,
you know, I could agree that it's the best hope we have of new approvals, you know, in the pipeline. But I would also recall that in my presentation, after 12 months, only 19% of those who responded were still progression free. So,
yeah,
you know, it's better than nothing. But some people may be having too high expectations. Maybe that's
right. And I think that's a really good point, that we don't know enough about how enduring it's going to be, and that's a problem. How many people, Len, remind us, what was the percentage of people that did respond, say PSA 50?
Okay, so it depends on your patient selection. If you selected for patients who tested negative for FDG and positive only for PSMA, then the number who responded was 49%. The PSA 50, 49%. In the US Vision trial, that number dropped down to 29% because they didn't eliminate FDG positive patients, or they didn't run an FDG scan. So those are the numbers.
So if there was concordance between the FDG scan and the PSMA scan, about half the people responded to the lutetium at PSA 50.
PSA 50, yes.
You know, I mean, to me, you know, if I think back over the last 12, 13 years, that's pretty fantastic.
Yeah.
I mean, that's about the best thing that we've seen in the last 15 years, I would say.
Yeah, I wouldn't argue that. Well, I mean, Enzoludamide, abiraterone, darolutamide, they all have greater longevity than that. But yeah, if you venture outside of hormone sensitive, you're right.
I just want to say, I see Mr. Baim just joined us. If you're looking for the multiple sclerosis group, Mr. Baim, it will start in about 10 minutes. This is the end of the other group. We're going to close this room in about 5 minutes and reopen it. So please come back in shortly. That's Ralph Baim. I see you just came in. Okay, let me explain about, before everybody drops off, what's happening with our meetings in February. We are switching our Tuesday meetings to the first and third week, and not the second and fourth week. The first and third week for our Tuesday meetings. That is because the first Monday and the second Tuesday follow each other in the month of February and the month of March. And as much as you guys love us, I suspect you don't want to come to 2 meetings in 2 nights, successive nights. So what we do is we change our Tuesday meeting, and next week there will be a meeting on Tuesday night at 3. It'll be at 6 o'clock Eastern, 4 o'clock, just the same as this meeting. The following week will be the first Monday. It'll be a normal meeting. The following week, it will be a Tuesday, and the following week, it'll be a Monday again. And because there's 28 days in February this year, the same thing's going to happen in March. And we thank Ben Nathanson for bringing this to our attention. So just watch out. Now, on Monday night, we're going to have a really exceptional presentation. I should have had the URL ready for you, but it was in the reminder. So if you've got the reminder, you'll find it in the URL. We're doing a presentation with Rachel Rubin on intimacy and sexual dysfunction, and it's going to include a whole bunch of different conditions, not just prostate cancer, but Jimmy Greenfield is going to represent prostate cancer, so I guarantee that he'll get her focused on some of the issues that you prostate cancer guys have. And that's it. So join us next Monday night. That is a webinar. It's not in this room. It's a webinar. You will have to sign up for it. I'm trying as I'm talking to pull up the URL for you. I'll get it if you just bear with me. And
will that be recorded by any chance?
It will, but we recommend that you sign up so that you get notification of the recording. But it will be recorded. It will be posted as a webinar. I'm just, hold on a minute. Recordings and decks, Rubin, intimacy. Here we go. Hold on, bear with me, and I will give you, here's the URL coming up right now.
I think maybe George Rovder already posted it.
Right.
That's great. All right. Thank you, George. Yes. Well, I'm also going to put it in here. There it is. Send it to everybody. And what we recommend is register, and that way you'll get a note from us when the recording gets posted. What we usually do is post it through our blog. It'll be on YouTube, and then it'll also get posted through our blog.
But it will be recorded so we can send it to other people to watch the recording afterwards, right?
Of course. Yes, of course. It's all free. It's open to anybody. And there may be some guys on here who have heard Dr. Rubin present. I don't know if Joel's still with us, but I think some of you might have heard. Oh, Jim Marshall's heard her present. He's putting his thing up. Gary Peters has heard her present. She's really good. Right, guys?
Yep, she's really good.
Yeah.
All right, Herb's blood sugar is plunging, Rick. You got to let him go to dinner.
Okay, goodbye, everybody.
Right, I'm going to stop the recording.
Okay.
Okay.
Good night, everybody.
Thank you.